On CCHF Talk.
So the question is is this going to last forever? They're spending so much money, right? When are they going to look at this and say, I'll tell you that the studies show that FQHCs save the system money. If you're providing care for the underserved and you're able to get them into your clinic versus them ending up in the emergency room and being admitted for a week, with $100,000 or $200,000 for that admission, you save money even with this high reimbursement rate. Studies over and over again show that. So that's probably our saving grace, is that the care we're doing is actually showing that it's saving. Even though it may be expensive, it's still cheaper than the alternative.
CCHF Talk is produced by Christian Community Health Fellowship, where healthcare providers, executives, and students come together to educate, encourage, and engage. Join us as we explore topics related to healthcare to marginalized communities. Those talks, those conversations. CCHF Talk.
Thank you. Good afternoon. I appreciate the opportunity to share with you folks. Let's start with a word of prayer. Father in heaven, thank you for the opportunity we have to share, and we just pray that it will be a blessing to those that are here in attendance, and also that the history of our organization will bring glory and honor to you. Ultimately, that it will be a testament to your goodness and your grace. In Jesus' name, amen. So this afternoon, we're going to talk a little bit. If I don't have my glasses, I can't see you folks. But then if I have my glasses, I can't see the screen. So I will just take them off, and then it's better, right? I won't be able to see you folks, but then I'll be less nervous because I won't be able to tell that there's people in the audience. But we'll talk about the history of SAC Health. And then Lee is going to focus on the financial considerations of becoming an FQHC. And then I'll be ending with just a few slides on the successes and challenges that we've experienced kind of with that FQHC model versus a free clinic. How many here are with free clinics currently? Okay. And that makes sense because we're talking about this transition. Then how many are with lookalikes or FQHCs? Okay. So, and then someone who's kind of not sure which one are you with a nonprofit company and then you rent the clinic and provide a free clinic in that space, mostly Medicaid. Okay. So hopefully this will be somewhat useful as we share our experience. Our history, we were started as from a church. Many organizations, or I know a lot of the CCH clinics started from churches. We were started from a university church in Loma Linda in Southern California, about an hour east of Los Angeles. It was a free medical clinic in the late 1960s. And this was really to serve across the railroad tracks and literally across the railroad track. Loma Linda being a smaller town, which had a hospital, was fairly well-to-do. And across the railroad tracks was the city of San Bernardino, which was not as well-to-do. And the idea was to provide free medical care for the residents who lived in the city of San Bernardino. So medical students started it with attendings that oversaw it. Loma Linda is a Christian academic medical center and has had a medical school now and been in existence for over 100 years. But in the late 1960s and 68, I just saw some information about the clinic just a couple of weeks ago. There were 300 volunteers in 1968 for this clinic, 2 paid individuals, and that could reflect some of your free clinics that you're doing. Of course, 300 volunteers is a lot. I think that's more because of the affiliation with the school that had a lot of students and folks who were interested in volunteering. And probably these 300 volunteers, like many of maybe your experiences, weren't 300 FTE of volunteers. They're probably the equivalent of 10 FTE of volunteers, but in 300 people, which is, of course, logistically is much harder to do than if you just had, 10 volunteers that were more full-time with you. Fast forward from the 1960s, 1968, all the way to 1995, and finally we had a permanent location, because I'll tell you, from 68 to 95, this was moving from place to place. Like maybe some of you folks, but at least for us, it was transient. We did not have a permanent location. So we were just doing it wherever it was available in the community. And that could be the basement. I mean, we were in the basement of the Salvation Army headquarters in the city. And so we used that for a couple of years, and then they closed down the Salvation Army. We had to move to a new location, a community center. So we never had a permanent location. It was whatever was available that the community would let us use until 95. And then there was a permanent location. And that's when finally Loma Linda said, okay, let's create a specific nonprofit that's called SAC, and SAC stands for Social Action Corps. That was kind of the term used in the 60s and 70s. That's where it comes from. But it's interesting that Loma Linda, as a Christian academic medical center, decided to start their community clinic as non-Christian, non-faith-based. And the idea that maybe, some of you have experienced was the concern that faith-based would limit the ability to receive funding from the government or from private. So that was the genesis now of our clinic from 95 up until we applied to become a federal clinic or lookalike in 2011, which is just a few years ago for us. So interestingly, in this time, we become a federal clinic in 2011, and we still don't have a designation as Christian, but we're culturally Christian because we were birthed out of an academic medical center that is still Christian today. And so you have similar kind of ethos and employees. But we went to the CEO at the time and said, maybe we should be a little more overtly Christian or have at least offerings of some Christian options for our patients. So we created something called a spiritual ambassador program, but this was a fully volunteer. And so we had about 3 or 4 volunteers that signed up for it. But after a while, they signed out for it because it wasn't working. We weren't referring enough patients to them. We didn't have a chapel, so they didn't really have a permanent location. We tried to integrate them with the providers. That didn't really work. So we created a space for them, but it was off the main clinic space, clinic floor. And so it just did not work. And so after multiple months of volunteering and only seeing maybe 1 patient that we referred to them in a week or 2 a week, it was too few. And then our volunteers left. It was also having leadership buy-in. There was a lack of identity clarity. We asked our CEO, at least someone here asked our CEO at the time, are we Christian or not Christian? And the answer the CEO gave is, well, it depends who you ask. And that's, a very open question or a very non-definitive answer from the leader of the organization. And then, since we still had this affiliation with an academic medical center, which had a chaplaincy program, they even trained chaplains at Loma Linda, we went to them and said, well, do you want to send us some free chaplains? Because, we always love free. That's the best word. Even once you're an FQ, you still love free, right? Free is still a good word. And so we thought, let's get these chaplains to come over from Loma Linda and help provide care. Obviously, what they said is our chaplaincy students get assigned to multiple locations. We already have assignment where they go, and they have to have an overseeing chaplain, and there usually needs to be some financial cost to that. And so they really asked us, where is your investment in spiritual care? Like they asked, are you planning to spend any money on this? And that was, to me, I was CMO at the time. It really was like an important question that I had to ask myself, am I putting any investment into this? So fast forward a couple, maybe 1 or 2 years after that, there was a change in leadership. I became the CEO, and I said, okay, we need to, we can't probably stand on the fence anymore here. We just need to either identify who are we, right? What's our identity, right? Saying that depends who you ask is not good enough. We need to kind of be one or the other. And so we did make a decision to hire a chaplain. We did get buy-in from the CFO at the time, at least for a 0.5 FTE to do this for 5 months. 0.5 FTE for 5 months. We had to show the benefit. And then the idea that it would become full-time if we saw that there was some financial, or if the organization was financially stable. And I think when we did this, actually, we were still waiting for reconciliation dollars from a rate set. So we were running in the red during these years. But I think it was super important for us to still make this financial commitment. We ultimately also looked at revising our mission statement and our vision statements and even our core mission statement and vision statement and core values. And then I think the hardest part was actually taking this to our board, because we decided we need to not only just change, obviously you can only do so much as far as changing your vision statement and mission statement and making them faith-based by adding Christ and your faith into it. But we also had to change our IRS status to actually become now a Christian nonprofit. And so getting board buy-in was a little bit challenging, but we did some research that we found that there are FQHCs that are all different faiths, not just Christian faith, right? And so we found there were Jewish, there's Muslim, there's Hindu. I don't know if you guys know, you probably know this. I didn't know it, but all different faiths that have actually started FQHCs. And so we took that to our board. There was quite a bit of discussion, I would say, at the board level, really about doing this. And we had the former mayor of the city as a board member, but we also had a board member that had come from a faith-based, another FQHC that actually filed for bankruptcy, and we had actually taken them on through that process. And it was probably that board member that said, look, you can do this, right? Because there was concern. Are we allowed to be Christian and federal? Can you even put those words together? Is that not an oxymoron? And it was good to hear from another board member who had already been on a faith-based or Christian FQ for 15 years that was not a problem. And we finally got board buy-in for that. We thought it could impact our other partnership. We had actually signed a partnership with Kaiser Permanente, and I know Kaiser's not super big out here, but it's very big on the West Coast, and it's actually the largest healthcare organization in the U.S. They're very successful, and we had signed a contract with them to actually see their Medicaid patients. After we signed this contract, then we would go through this whole process, and we changed our mission statement and everything, and I remember they were coming to visit, to do a site visit, to see everything that we were doing, to kind of it was 2 or 3 months after we signed the contract, but now all the leadership team from them were coming. And I thought, do I tell them? Do I tell them who we've become now? Is this an issue? And of course, God said, yes, you need to be honest and you share with them. And so I remember, scanning the room as I'm sharing the new mission statement, right? After we signed the contract, you couldn't tell by the faces of anybody, but when we were walking and doing the tour of the clinic, the 2 leaders of the counties where we were in of Kaiser in those 2 counties, they both whispered in my ear and said, "Thank you. I'm a follower of Christ. Thank you for, your new mission statement." So that was validation, right? That it was the right thing. They couldn't say it in front of all their team, but they could definitely say it individually. I guess I can say it now too. Sometimes I don't share that story because it could get back to even, the team there. So then we went to a partnership between this big academic medical center, Loma Linda University, and, a small, FQHC. Now, the history with the medical school founded in 1909. They started a GME program in 1946. So they've been in this business for a long time. In 97, they were actually capped at 300 residents. Today, there's actually 800 residents that Loma Linda has. So you can imagine these additional are being paid by the hospital, not being paid the normal route, which is through Medicare. But in 2010, this is even before my time with SAC, there was a decision made by the saying we're going to partner with an FQHC to do all of our residents are going to do their training at this FQHC. Now, the problem is they didn't have an FQHC to partner with. They literally decided we're going to change our community clinic into an FQ. And so that's what they did. They took the community clinic that was their community clinic and then changed it, and we became a lookalike in 2011. So this is kind of the partnership before the for the academic medical center in 2013, because it became a lookalike and only some residents moved over. So in 2013, which was right when we were still a lookalike, there were 150 residents in the primary care world at Loma Linda in the family medicine, internal medicine, and pediatric clinics. The physicians were paid by hospital, but I would say that's academic rate was actually under market rate. So it was very difficult to recruit doctors and to retain physicians. The staffing in those clinics that Loma Linda was running for their residency training was very bare bones staffing structure. And the patients were really not enough patients for the residents to actually get experience. And it cost about $7 million that the hospital was paying to run these clinics because they were all running at a loss. So they were being subsidized to the tune of $7 million, which makes sense of why they decided they wanted to do a federal clinic type of model. We ended up creating a consortium, and that's the Loma Linda Health Consortium. And that includes the academic medical center and the federal clinic. So that's the combination. So you can see now, 10 years later, after this fact, that now there's over 500 residents that rotate within our federal clinic in 44 different specialties and subspecialties. This is an amazing blessing for our community to have access to these type of specialists. And it's just a night and day difference than 10 years ago when I had to refer to the county hospital and it would take about a year to get in and then probably a year later to get the note back. By that point, I didn't know why I referred the patient. So now it's such a night and day difference. The physicians are now paid by the federal clinic at market rates, which helps us to recruit and retain. And the staffing is patient-centered medical homes, level 3 type of staffing. So it really has made a huge difference. Now we actually have a waiting. We can't get our patients, like we probably have more patients than we need. And I'm looking at Dr. Krautz, who's our quality, our chief medical officer of quality. He always says that, we have a waiting list for patients to try to get in and get care. I mean, they're waiting like a month or two for new patients. So we have 65,000 patients now that we're serving, and it's a lot, even though we have grown to try to keep up with that. The cost now, by the way, to the hospital is zero, which they, of course, and it's been definitely a blessing from a financial side for the hospital. So it really was a strategic decision for them, 14 years ago to say they wanted to move in that model. But I think it's also been a win-win even for the community in order to get access to this type of care and level that they've been able to receive. So now Lee's going to talk about the financial considerations that went into all this.
If anyone was in this session this morning talking about the size of God, I was at the Grand Canyon last week, and these little people standing in the vast Grand Canyon reminded me just how big our God is. Shared a picture of my beautiful wife and our family, my dog, and we love to be outdoors. My personal professional mission is to help health centers succeed. And when I heard about CCHF a couple of years ago, God just ignited this flame in me, and have really enjoyed visiting with a few of you on some of the challenges that you're facing. I'm a certified public accountant by trade. I've worked with FQs across the country, and God is trying to expand the kingdom through CCHF and through our story. And so we are just excited to share a little bit about the lessons that we've learned, some of the things that have the challenges that we've faced through the years, and I would love to walk alongside you as we build that network that Dr. Donlin shared about this morning. A little bit of an overview of the FQHC program for those that do not know. There are approximately 1,500 FQHCs, federally qualified health centers across the country, in 16,000 delivery sites. Some of these numbers are just absolutely astounding. 32.5 million people served, about 1 in 10 Americans are seen in an FQ. And you see 1 in 5 uninsured, 1 in 3 people living in poverty. So the reach and the breadth of the FQHC program is growing and has expanded certainly for decades. Started in the 60s, has enjoyed strong bilateral support through the years. I'm excited for our CCHF map to someday match the health center service delivery map, and I believe that we are. Just as an overview of the FQHC program, there are 2 methods of attaining FQHC status. When we visited with Steve about this overview, he said, make sure you tell them this is not for everyone. And so we are certainly emphasizing that some of the challenges of the FQHC program, some of the requirements, it is not going to be for everyone. But today we just want to give a little bit of an overview of some of the challenges, some of those benefits, and just share our story. My pastor likes to say, we as Christians are blind beggars pointing others toward food. And realistically, that's what SAC Health feels like, is that we have found an avenue that has helped us grow and expand services to our community. So there is one avenue of filing to become an FQHC lookalike. And so that's the column on the right. And so when you compare the two columns, there are a few notable differences. The FQHC lookalike application is really a compliance application. It is not competitive. Realistically, are looking to see, can you or will you or are you in compliance with HRSA's expectations? SAC applied, became designated in 2011. I love that Dr. Lohr likes to share. So we are teenagers at this point. We're a 14-year-old FQHC that have gone through a lot of growing pains. And so for us, this mechanism has helped us to expand our service to the region. But again, Steve, it's not going to be for everyone just because of the challenge. Is a fully funded community health center. You'll hear those two phrases interchanged: community health center, federally qualified health center. Those two monikers are interchangeable. The FQHC grant application, approximately $650,000 in grant funding per year. It is very, very competitive. The last data that I saw, less than 40% are funded. SAC became an FQHC in 2013. So we started with that lookalike designation status without a federal grant. And then in 2013, we were awarded that federal funding. And as you can see, the cadence of those grants through my career, 2007, 2010, 13, 14, 17, 19, 20, and 24. So about every 2 to 3 years, somewhere in that neighborhood, there is an opportunity for that application to come out. And along with that, certainly is the benefit of that grant funding. Now, thus far, since the 60s, that funding has been into perpetuity. So that is an annual grant, $650,000 per year that helps to subsidize many of the costs and the challenges that you are facing currently as free clinics, or in some essence, some of you lookalikes as well. Now, the money guy looks at this line of this enhanced reimbursement, Medicaid and Medicare. As an FQHC, by federal statute and regulation, for any service rendered to a Medicaid patient, you receive cost-based reimbursement. So each state is very different, but there is generally some calculation that says your total costs divided by your total visits, and you're going to be made whole. You're going to be reimbursed at that rate. That typically is well over $100, whereas on a fee-for-service basis, for those that are billing Medicaid and a non-FQHC, Medicaid and Medicare reimbursement is typically much less than $100 per encounter. And so for us, that has been a significant benefit. Over 90% of our patients are Medicaid. In California, that's called a Medi-Cal program. And so to be reimbursed instead of significantly less than $100, but instead to be reimbursed at our cost for those visits has really helped fuel our growth. Horrible slide. Too many words, but this is to say this application is difficult, and that's why this is not for everyone. Very challenging, 50 to 150 pages of documentation showing to HRSA that we are in compliance with all of these requirements. And so it's one thing to consider. There is a cost to some of these benefits. So how many of you hate numbers? How many of you just are just okay? So we're going to kind of move through this. There are a lot of numbers, but for I thought this was good just to kind of illustrate a few examples of some of the benefits of the FQHC program. These are 6 of my clients that I worked with, looking at 2017 to 2022. What that growth was like for them on over that time period. So Clinic A in 2017 had $35 million in revenue. In 2022, about $102 million. And so they experienced a X increase then in revenue on the revenue side. Clinics B, C, D, E, and F, you can see their growth, all of them kind of growing even throughout the pandemic and COVID. But in aggregate, if you were to kind of total up all of this growth, adding them all together, all of these clinics at least doubled their revenue from 2017 to 2022 timeframe. On the expense side, looking at that same growth, 2017 to 2022, they also grew at an 82% rate. And so from a net income standpoint, you can see there was a significant growth when you add up all of this income together. These 6 clinics had about a $44 million increase over that 5-year time period. So a lot of numbers. I want to give you an opportunity to stand up. Let's do the Midvale School for the Gifted stretch. We can do the my brain is full stretch, 4:00. You made it to the 4:00 session. Sorry for all the numbers. Feel free to keep standing if you need to. I understand. So how did they do this? We're going to talk a little bit about some sustainable business strategies. John Wesley said, make all you can, save all you can, give all you can. I think that the first thing that comes to mind when you say nonprofit is that we are not supposed to be profitable. And what I would say that I encouraged my clients and we at SAC, certainly you've heard no margin, no mission. There's an earlier session today that had a great title, Profits and Profits. And I thought, we missed a chance to kind of play around with our titles. If I were to retitle this, I would say, we are looking for net kingdom. Right? I mean, realistically, that margin that we are seeking to generate is to continue to build out that network and to reach more patients. And so when you think about that, I like to offend all of my clinicians and say, realistically, we are just making widgets. When you think about an encounter or an office visit, at the end of the day, I have fun with numbers and I try and boil this down to something very basic. Let's think about if you look at California. This is national data from 2023. If you look at total visits, there was 25 million encounters in California. The total operating budget of all of the 150 plus FQHCs in California was about $9.9 billion. So if you divide that, 9.9 billion divided by those 25 million encounters, the cost per encounter, the cost to make that widget across the board was about $388. On the national average, slightly more. Every FQ, those 1,500 FQs across the country, their total expenses were about $46 billion. There's 119 million visits nationally to those 32 million patients that we saw earlier. So the total cost to make that widget was $387. So on the revenue side then, if you take that same math in the state of California, the total net income was $393, pretty similar on the national average. So we actually did have some net income across the board when you look California versus national. So I would encourage you and your teams. I was sharing with James at dinner last night that some of these conversations with providers about productivity can often be very challenging. I know that clinicians feel overstretched, and the conversation that I like to encourage medical directors to have is to do some of this math and say, realistically, if we are losing money on a per encounter basis, there's only two things that I can do to right the ship. I can either be more productive, right, to make my cost of making that widget smaller, or I can cut expenses. And I don't think anyone is interested in taking a pay cut. And so sometimes kind of boiling this down to something very basic, you can realistically compare this across the board. So I think one thing I would encourage you is to think about some analysis over what does it cost you to produce an encounter and comparing that to the revenue side. So the other thing that is interesting to me, the FQHC program, certainly, even if you're a fully funded grantee, does not solve all of your financial problems. If you look at this national data again, in the state of California, 27% of California FQHC's revenue was from non-patient income. So that's from grants, that's from donations, that's from other sources of income. So even though we are being reimbursed at our actual cost, there's still need to subsidize that cost. And then nationally, about 31%. So that diversification of revenue, we talk about that all the time at our clinic. As we moved from that free clinic model, really requiring 100% support from an outside organization, into an FQHC world, as we've grown and expanded, we still are always looking for ways to fill that gap. So before you apply, consider the costs. If I haven't dissuaded you already by the graph, by the challenges of this, there certainly are costs to be outweighed. In our expansion subcommittee, we're driven by this verse, Mark 14:28. Suppose one of you wants to build a tower. Won't you first sit down and estimate the cost to see if you have enough money to complete it? And so as you considerate and deliberate the FQHC model, there certainly are startup costs, application costs, probably some additional staffing required. We have built out some robust quality staff to help with some of our reporting for HRSA, for our FQHC designation, as well as capital costs. And then, as Dr. Lohr alluded to, there certainly were some many red years for SAC Health, where during that initial startup, during that time frame, as you are getting up and running, it is quite common to experience operating losses. But as you move forward, kind of through that growth and through getting right sized and diversifying revenue, you saw on the other slide that there certainly was a benefit on the other side of some of those losses. So how will we build a strong foundation as we make this transition? For SAC, one thing that we have instituted is a prayer before virtually every leadership meeting and a lot of our subcommittee meetings. Dr. Lohr, if we have time, can share about our some of the amazing miracles that we've seen at SAC, including preparation for telehealth after the COVID during the pandemic, recruiting mission-aligned leaders. That has really been important for us as we have built out and made this transition of people who believe in the mission and are able to help build that foundation of fulfilling our mission. Want to close out with a quote from N.T. Wright. Doctor shared with me, a British scholar who is really resonating with me, this beautiful picture of the church. And as I have sat through and I've thought about CCHF and the net kingdom that we are building, and this network that we are building, I thought this was a beautiful picture that our expansion subcommittee is starting to think about. The church has always been called from the beginning to be the small working model of a new creation. And you can see that in Acts 2 and in Acts 4 and then going on. The church is to have this vision of what God's new world looks like, We are to model that in the present as best as we can. And that will be out of sorts with the world around us. But people will look and say, oh, I didn't know you could live that way. Oh my goodness, that's different. How does that work? And well, we're following this person called Jesus, and this is how he taught us to live. So I think for SAC, as we have made this transition, even though all of this heavy lifting, the operating losses, the challenges that we have undergone, we are entering the next phase as a teenager, as an FQHC teenager, and we're starting to be able to dream a little bit of how do we play out this working model of a new creation for our patients. So as we talk about partnerships, and Dr. Lohr shared that our affiliation with the Loma Linda University, I see many free clinics. I see many FQHC lookalikes who are trying to do this on their own. For us, our partnership with a big brother has really been the piece that has helped us grow and expand. We also really focused on cultivating a relationship with our Medicaid managed care organization. For us, not every state has managed care, but I thought that this flywheel was interesting. This is a good way for me to visualize the way that we can build synergy through partnership with managed care organizations and our big brother. As you see more patients, as you are able to recruit physicians, that helps us lower that cost to make a widget. We are able to improve quality care. And that has really been a picture of some of the ways that we have tried to envision our growth and our strategy as we look to expand service. So want to hand it over to Dr. Lohr to close us out to talk more about our partnership.
And I understand this is not necessarily going to apply to everyone. This is our experience with the partnership of having this academic medical center. Blessing that, we've been able to add some permanent healthcare jobs. The pipeline has been really probably the most of a blessing. We are blessed because we have a pipeline all the way from medical assistant to kind of resident. And that's a huge spectrum, and everything really in between, from PA, nurse practitioner, social work, psychology, marriage and family therapy, like all of these are, sometimes the unicorns that are hard to find, but has been such a blessing for us to have the pipelines for literally every single layer of healthcare worker, and being able to then kind of expand into the footprint that we have. And we're now moving into a big building, right? And it's a lot of money, $120 million facility. And it's just been a blessing to be able to do that. And I think Lee put this on a slide. He didn't mention, we decided to start doing telehealth visits in November of 19, and our first telehealth visit was scheduled in November of 2019 for March 12, 2020. I don't think that was just a coincidence. At least in California, March 12 was the day before Friday the 13th, which was March 13. And that was when we had to shut down in our 2 counties, our clinics, to anybody who potentially had symptoms. So the fact that we had our first telehealth visit the day before, and then we were able to roll that out, that was a God thing, 100%. I shared that, by the way, with the Kaiser folks as a testament of God's goodness to our clinic. And then there's just been multiple other answers. This $120 million, by the way, $85 million we had to get a loan. The banks wouldn't give us a loan of that much because they said, we're not touching you guys with that much money. We're not going to allow it. We had to go to multiple. We finally found a private family who's giving us an $85 million loan. They're a Christian family, and they don't want to be named, probably because they don't want anyone else asking them for loans. But it's just a God thing. I texted them, thank you for allowing us to be a blessing to our community. And they wrote back, thank you for allowing us to be a part of that. They have billions with a B and an S. We didn't know anyone else who could do this for us. And they didn't know anything about our clinic. We literally sent them information about it, and over a weekend they prayed about it and then told us. But that's a God thing. That's 100% God thing. And I tell our employees this: if God can provide us with an $85 million loan, it would be great if it was an $85 million gift, right? He could always change it into that. And we're still praying for that. But if he can provide us with $85 million, even if it is a loan, he can provide us with anything. I mean, he's a God who owns everything. So it's, that's definitely been a blessing. There have been, these are the successes, right? We have boards on both sides that are committed to this teaching health center. We have a facility that's designed to be able to train residents. We use the same electronic medical record. All of the physicians have an academic faculty appointment. And then we have medical directors within the FQ that happen to also be Loma Linda employees because that's how it works, but they're still full-time committed with us, and they work with the program directors because that sometimes can be a challenge. And then when we have bonuses, we share it freely. So we share it with the residents that are doing their training because we want them to feel like they're still a part of us. They're seeing our patients. By the way, 50% of our patients are seen by residents. 50%. That's 110,000 patient visits a year seen by residents. That's a lot. What are the challenges? The board composition, to be honest with you, we have 4 of our 12 board members. That's a third are Loma Linda employees, including the president of Loma Linda sits on our board. I will tell you that he started the community clinic, was part of the starting of that back in the 1960s. So he's very much a champion of the FQ and our model, but he still is the president of Loma Linda, right? So he has that hat as well. Fair market value, we actually rent buildings from Loma Linda because we didn't have the capital to buy and build our own buildings until this most recent one, and we got that private loan. Before that, most of our facilities were owned by Loma Linda, and then we pay a rent. And then we pay for their physician services and we pay for their Epic, because we couldn't afford Epic like on our own. It's usually hospitals that do that. And so we pay for that. And then this melding of cultures, right? Teaching versus the productivity and patient access need, right? If it's up to the teaching, we would see less patients ultimately because there's like, oh, well, we need time to teach. We have medical students, we have residents, they need time. And we have to kind of balance that with the patient access needs, right? We have so many patients, we have needs to be able to see them. And we do have the sustainability piece financially. Some of the other challenges, even with our brand identity, here we're in like the shadow of this academic medical center. It's been around for 100 years. It's actually well known. And people know it as a faith-based organization. They want to go to it. 12 years ago, when I would see patients and I had to refer to the county, they wanted to go to Loma Linda. That was like, you're going to the best hospital in the region. It's the only academic medical center in the region. So it's known for quality and it's known for faith-based. And our patients, majority being a minority, they wanted faith-based. Like they like that value add that they receive. So it's nice now to have all of that available. And we're also, openly faith-based with our clinic as well. But when we started talking to Kaiser, I'll tell you that Kaiser Permanente is a direct competitor with Loma Linda University. So here I'm like, okay, I'm going to sign this contract, but it's like, I remember sitting around the table and the president of, Kaiser and the president of Loma Linda were there and they were asking who's going to make the final decision. And it was very awkward. I'm sitting in the room and I said, well, I guess we'll have to ask my wife. She makes all the decisions in my home. Ultimately, it was really us as the clinics, our decision, but but obviously they, in healthcare, there can be some competition. And I think quality is also a challenge. Sometimes we have so many residents, like I mentioned, 50% of our patients are seen by residents, and residents come and go, right? They come and then they leave. And in that turnover, that constant turnover to train them how to see patients in a federal clinic model, that's hard, right? Because there's a lot of things that we have to do in order to document how we see patients and what we do with them. So those have been kind of our experiences when it comes to that. We want to open it up for questions. Again, I know this is a very unique model that we're gone through, but obviously it still went from a free clinic, completely free, at least from the 60s and 70s until 95. I think we started charging for, we had contracts with Medicaid and other programs in 95. But how we got funded during all those years was really a community benefit grant from Loma Linda. Like as a hospital and a nonprofit, they were required to have a community benefit grant. So we were about maybe a $1 to $2 million budget. during those years with, one or two doctors and one or two dentists. And I don't know, I think we had some behavioral health, but that was before my time. So that's how it was fully funded until, of course, the FQ. Yes.
The question was, can we describe the operations and our scope at the time of our application in 2010? Like many of you, we were operating as a free clinic, really not really sure of what the FQHC designation was going to mean for us. And as Dr. Lohr shared, we were on a smaller scale. We did the best that we could. As you saw, the application requirements, very extensive. And so we did hire consultants to help look at that, to understand what those requirements were. I think the application was honest, but there's also some aspects of it that would say when we become a full FQ, then we imagine that we will be able to implement this more fully. So we were providing medical, dental, and behavioral health. I'm confirming at this time. So we were providing the same services that we were in terms of meeting every letter of the law of the FQHC application. I think there were portions of that we had to grow into, so to speak.
Yes, James.
Anyone that couldn't hear, there was an opportunity to meet HRSA's expectations in James's situation where they could put together a corrective action plan. So for any areas that they were not in full compliance, they were able to remedy that within a certain time period.
Yes.
So what I did for that slide is I took national averages. So the national average per encounter was about $380 per encounter. So that is the approximate state average for Medicaid and Medicaid reimbursement. Medicare PPS is around $200, somewhere in that neighborhood. So that slide that presented those numbers, the first line was patient revenue. Yes, thank you. Patient revenue was the revenue from services, 73% in California, 68% nationally. And so this slide is to say that there is some still a requirement for outside funding, grants and other funds. Each state has different rules around that. That is Medicaid is nuanced for each state, but it's generally total expenses divided by total encounters, as we've done here, to establish your reimbursement rate. It's different in each state. There's different rules and regulations in each state.
Question. So the question is is this going to last forever? They're spending so much money, right? When are they going to look at this and say, I'll tell you that the studies show that FQHCs save the system money. If you're providing care for the underserved and you're able to get them into your clinic versus them ending up in the emergency room and being admitted for a week, with $100,000 or $200,000 for that admission, you save money even with this high reimbursement rate. Studies over and over again show that. So that's probably our saving grace, is that the care we're doing is actually showing that it's saving, even though it may be expensive, it's still cheaper than the alternative. Yeah. So that's a good question. We get asked that question all the time, especially by the academic medical center. Is this going to last forever? Like, what happens when, there's a new administration? By the way, FQs have been supported from 1965 to today, both sides of the aisle, bipartisan support. There's been growth every administration, including Trump's first administration. There was growth of FQHCs across the nation. So now DOJ is new, and Trump is probably not fully Republican or Democrat, right? He's kind of his own thing, but we don't know ultimately what's happening fully with this administration. We probably don't know any day, because tomorrow could change, and next week it'll change too. But ultimately, we do have that history that serves us well, and a lot of data. Thank you all. Appreciate it very much. Blessings to all of you.
Christian Community Health Fellowship exists to encourage, engage, and equip Christians to live out the gospel through healthcare among the poor and marginalized. If you enjoyed listening to CCHF Talk, make sure you follow, like, and share on Apple Podcasts, Spotify, Deezer, or wherever you find your favorite podcasts. To learn more about Christian Community Health Fellowship, visit cchf.org and follow us on Instagram, Facebook, and YouTube. Join us next time for another episode of CCHF Talk.